Hello, and a very good evening to everyone. I, Tanvi Golla, an MSc student at IBAB, take immense pride to be your host for today and would like to welcome everyone who are joining with us to the 8th episode of the Coronavirus webinar series. The motto of our team is to spread awareness among the audiences who have no formal training in biology background. It became a necessity to educate people across who are misinformed in various aspects in the prevailing COVID-19 situation. And we hope this talk helps and understand the diagnostics approaches of the COVID-19. So the today's topic is Nuances of COVID-19 Diagnostics When There Is No Perfect Test by Dr. Anurag Aggarwal, a medical researcher and the director of the Institute of Genomics and Integrative Biology, New Delhi. I would now take a few minutes to introduce our today's speaker. Dr. Anurag Aggarwal is an Indian pulmonologist and is known for his study on lung diseases and is a senior fellow of the DBT Wellcome Trust. He is also a 2014 Shanti Swarup Bhatnagar Prize for Science and Technology awardee. He is also a recipient of the National Bioscience Award for Career Development of the Department of Biotechnology, which he received in 2015. He currently heads the lab on respiratory diseases in IGIB and is involved in translational research on disorders such as obesity, asthma, and diabetes. With this, I welcome Dr. Agarwal and request him to enlighten us today with his talk. On to you, sir.
Thank you very much, Tanvi. An absolute pleasure to be here. One very interesting thing I heard when you spoke was that most people do not have a biological background. I'll try to keep that in my mind as I talk about the nuances of COVID-19 diagnostics. When you asked me to give this talk, I really thought the most confusing thing out there is that there are so many tests. And yet, we're always talking about why aren't we testing more? Why aren't we doing RT-PCRs? Why are we doing antigen tests? Somebody comes always and asks about, shall I get an antibody test done? What does that mean? So I thought this would be a good topic to take up and basically highlight two important things that I will state even before we get started. There is no perfect test for this disease. In fact, in medicine, for most diseases, it's usually a context of what is it that we want to do, what is the purpose of testing, and then matching it to the test that best answers the question in the clinician's mind. With that said, I'm going to roll through my slides. I don't have too many of them. There are only about 20 slides or so. But I will try to take some time because it's a non-biological audience, at least some parts of it, to explain whatever I think merits detailed explanations. So before we talk about COVID testing, I thought I would start with something much, much simpler. Almost the symbol of being a doctor. Every time you look at the photograph of a doctor, it's either scrubs or a cap or a steth around their neck. If you look at centuries of evolution of medicine, you will find a wide variety of stethoscopes have come and gone. Everything in this picture is basically a stethoscope. From hundreds of years ago, they used to have, basically, if you can see my arrow, these basically are old wooden stethoscopes. People used to put it to the ears and listen to breath sounds. In a modern generation, you have something like this. You basically have the thing that you hang around their neck with a piece in the front that collects the sound, two earpieces, allowing the doctor to hear. And over here in this corner, with a tablet, I have what is called a point of care ultrasound. Now, point of care ultrasound is also using sound waves, but in a very, very different context. Now, this is a historical picture. A doctor with his ear to the chest of a patient, trying to listen to the lung sounds, telling him what the patient might be having. Now, that could be a pneumonia, that could be tuberculosis. In a modern day, it could be COVID-19. And obviously, you can see it's not an optimal way of trying to hear something about the patient You are far too close, and you can't possibly hear that well with your ear pressed against the chest. And there are two ways one can go about it. In one way, we could think like an old doctor's approach. There will be something very specific about the way COVID-19 sounds in the lung, and we could invent better methods. We could have a steth like here at the bottom right. There is only the front piece, there is no back piece. The entire sound is being broadcasted by telemedicine, and you could hear it from another room while the patient or somebody else in a PPE presses it to the chest. And you could make better receivers, better sounds. You could clear it up. You could listen to 10 different sounds in the lungs at the same time. All these possibilities exist until you ask yourself the question, why am I trying to hear the lung sound? I am trying to hear the lung sound because I believe that those sounds will tell me something about what's happening to the lung. At that point, you could get a little bit more nuanced in your thinking, and you could ask yourself, well, why don't I generate an image of the lung in that case? So you could put an ultrasound probe shown on the right hand side, and you could actually generate an image of the lung below the probe. And what you would find is that wherever the lung is having pneumonia, you'd get these streaky lines like the one shown with this arrow. Once that is done, you could stop using the steth altogether, and you could now focus on using ultrasound to generate lung images, which might be a bit easier to distinguish between people with one type of pneumonia versus another versus simple bronchitis. Now, I say that only to illustrate a point. And the point is, tests are always with a purpose. You must understand the test and the purpose to really decide what is it that you want to do. And that becomes even more applicable as you move from simple tests of the body to molecular tests. So what's an ideal diagnostic test? Let's start with a SARS-CoV-2 infection. We'll come to COVID-19, which is a slightly interestingly different world a little while later. You want this test to be positive early in the disease. Why is that? Because what's the entire point of SARS-CoV-2 testing in the community? To find the people who have it and isolate them. So if the test is not positive early, you're going to miss multiple days at which point the disease is being spread. Second, you want it to be accurate, obviously, and you want the predictive value. If it is positive, it should be positive. If it's negative, it should be negative. You want them to be high. And that's something that I'll talk a little bit more about later, how that gets very, very nuanced. The third, you want the time in which you go from a biological sample to an actual diagnosis to be low. Because if it's very long, you don't get back the result to the patient in time. And if you don't do that, the patient will go around spreading the disease further. Then you want, especially looking at India, the infrastructure requirement to do the test to be very low. If it requires lots of bells and whistles and labs, you can't do it everywhere. If you can't do it everywhere, you can't keep the time low. If you can't keep the time low, you can't keep the cost low. Practically, the test will not get done. And I said the next point already, you want the cost to be low because how many people do you have to test? In a disease like COVID-19, you have to test 1 million people a day at the very minimum. That's where we're already at, and we still need to go up further. If the test is not cheap, the cost will become prohibitive and unaffordable to people or to the government. And last but not least, the test must be scalable. Back in March, we had the PCR test, but our capacity was maybe a few thousand tests a day. What can you do to prevent a disease like COVID from spreading in a country of 1 billion people if all you can do are 1,000 tests a day? It simply can't be done. So what are the main types of tests? Let's think about it logically more than by the names of tests. There are many names of a variety of tests. In the end, you have a virus and you have a host, and the virus will infect the host. So if that is true, there are only a few things you can do. First, You can detect the virus. You can detect that either by detecting the protein of the virus or the RNA of the virus. It's an RNA virus. RNA is a bit preferred because you can amplify it. So there's a very small amount of RNA. You can amplify it so it becomes easier to detect. But if you had a very sensitive test, you could also detect the protein, typically called an antigen test, and we'll come back to it later. And because it's easy, there is no amplification step, you just directly go with something like a pregnancy test. So when you do a pregnancy test, what are you doing? You detect something called HCG, it's a protein. You're detecting it in urine. Very easy. You simply pee upon the strip, a band comes, and the test is positive. So in theory, a protein-based test for COVID-19 is that simple. You take a biofluid, you put it on a test strip, it comes back positive, you get a band, and you are done. Just a few minutes. But the amount of virus is often very small, so sometimes you run into trouble, although it is the easiest. The other way, if you're not going to look at the virus, is to look at the human response to the virus. Now, this comes under two categories: the immune response, the antibody, or the cells, or some other type of response. So, for example, the lungs are filling up, you can see it on the imaging of the chest. And many people are talking about looking at how your voice changes, how your breath changes, maybe the smell of your breath changes, maybe the physiology of your heart changes. So, all these things that are normally taken for granted, perhaps there will be a subtle change in these parameters that allows you to specifically detect COVID-19. Now, when you talk about antibodies, cellular response, imaging, these are things you understand. These are naturally specific things that you know how to build the tests. The problem is the response can only come after the infection. So they'll all be a bit delayed. They're not going to be positive on day 0 or day 1. In fact, nucleic acid is positive on day -1. Even one day before you get the disease, the nucleic acid will probably be at its peak. But these biomarkers of active disease are likely to be positive late, and in the case of antibody, much later. So what is the nuance about all this? Why did I pick the topic of nuance testing? And I'm going to get to that in a few relatively complicated slides. Let me explain a few things. Even before you do a test, you must ask yourself one question. What will I do with the results? And will it make any difference to what I do? If you're going to do exactly the same thing that you are going to do without the test, you don't need a test. And assuming you plan to do something different, then you probably have a probability in your mind. What is the probability this test is positive, the probability it is negative, even before I start doing the test? And that can be thought of as what is the probability this person is infected. The second part of the nuance are the characteristics of the test itself. The first one is not about the test, it's about the person you are testing. The second one is about the test. Is this test logistically possible where I want to do it? Does it require, transport of frozen specimens into an area where there are no couriers? Number two, technical parts. What type of equipment and sample collection is required? And the last part, the clinical part, what do I plan to do with the test result once I've got it? And that ties in very nicely with understanding the purpose of testing. Because clinically, there is a reason why you're doing the test. The test characteristics are tied to that reason, and the purpose could be isolation, the purpose could be treatment, the purpose could be, is this patient exposed, has he recovered, is he immune? And these are the type of questions that are very important when you choose the type of test. Now, this is probably the busiest, most complicated slide I will show you throughout my talk. So let's walk you through a few basic concepts. There is something called likelihood ratio. Likelihood tells you the odds of a given person having the disease or not having the disease. Now that likelihood exists even before you do the test. That's called the pre-test probability here on the x-axis. And then there is going to be a likelihood, the post-test probability after the test is done. And the test will change it if either it is positive or if it is negative. Now, every test, when it is positive, will increase the likelihood. Every test, when it is negative, will reduce the likelihood. And there will be a ratio by which it changes the odds. So there will be odds, the person has the disease. These odds will be acted upon by the likelihood ratio of the test, whether it is positive or negative. And after everything is done, you will get a new probability of the person having the disease, calculated as odds, but expressed as probability. So there are two parts. The pretest probability that is completely independent of the test, and then there is a likelihood ratio that is only determined by the test characteristic. Now a test has two words, sensitivity and specificity. Sensitivity is again very simple. If you had 100 people who have the disease, how many will the test call positive? Specificity is if you had 100 people who do not have the disease, how many will the test call negative? So when you want to calculate the likelihood ratio of a positive test, you are fundamentally looking at the ratio of two things. The likelihood of a positive result coming from a person with disease or a positive test coming from a person without disease. The likelihood of person coming from a person with disease is sensitivity, and the likelihood of that test positive coming from a person without disease is 1 minus specificity. So likelihood ratio positive is equal to sensitivity divided by 1 minus specificity. Now likelihood ratio negative is exactly the opposite. You're looking at the likelihood of a negative test coming from a person with the disease. That's 1 minus sensitivity. And the likelihood of a negative result coming from a person who does not have the disease. And that is specificity. And so these ratios can be, anything from 1 to 100. They can be 1000 also. Like I said, they're only derived from this ratio. And you can see how the curve changes. So let me take one line. Let me take the pink line and the orange line. Now in the pink line, there is a test that has a likelihood ratio positive of 30. When a person, even with a small pretest probability of 10%, tests positive, I basically find there's 80% probability the person has disease. Now, on the other hand, when I look at the orange line, a person testing negative, I can find even at 70% likelihood of a person having disease, the after test probability, if the test is negative, is 5%. Now, typically you want your probability of the person having disease should be about 90% for you to send them to a quarantine center or a hospital. And for you to send them home saying nothing more needs to be done, you would like it to be 5% or less. So pretty much every test has a line like this based on its sensitivity and specificity. And based on how these parameters are, some tests will be useful for low probability people, some tests will be useful for high probability people. And this is the biggest nuance that is often overlooked when you talk about COVID-19 testing. And I will speak one line again because it merits repetition. The predictive value of a test, which we want to be high, depends not only on the test, but also the clinical context in which you do the test. So there is no way of separating a test from the intended use, and that is the biggest, most overlooked nuance when we plan strategies for a nation. So why am I speaking so much on this topic? What has changed so dramatically from other diseases? I mean, after all, medicine has been going on for years, right? H1N1 has gone, dengue comes and goes, tuberculosis has been around forever. Why do people not talk about these topics in those contexts? What's different this time is that symptoms are not being very helpful. You know the idea of trace and test, trace, test, treat, right? Trace, test, isolate, treat. The golden words on which containment of COVID is built. Well, every test leads to more tracing, and without tracing, there is no testing because you're not talking about only testing people with symptoms, you're talking about testing people who might be asymptomatic. Why is that? Because SARS-CoV-2 infection is often transmitted asymptomatically, and many of the super spreaders are asymptomatic. So far in most diseases, we first use clinical symptoms to stratify people and get everybody in this previous graph to a point of a high pretest probability. And you can see at a high pretest probability, even tests with likelihood ratio of 5 function well, which basically mean that the sensitivity may not be great, 1 minus specificity might be not that low, and still you'll get a ratio of 5 and you can still use the test because the pretest probability was high enough. But in COVID, that is not true. In COVID, you often have to test people who are just contacts. These people are going to be in a low pretest probability state, and trying to figure out this likelihood ratio is so critical. And I'm going to walk you through an actual example, step by step, to try to explain to you how one thinks. If one has a test of 90% sensitivity and 90% specificity, right? These look like good numbers. Almost any test with these kind of numbers would normally be approved because this is what you look for. And you were to test 1,000 people in a day, and out of these 1,000 people, 100 are symptomatic and 900 are asymptomatic. And I'm telling you, this is a typical day in the life of COVID-19 testing. This is what the healthcare workers who are out in the field are dealing with every day. And this is why this discussion to the people like you who will invent the tests of the future is so important. Now let's put in a few more numbers. Let's say that you expect about 5% of the people to be infected, which means 50 people out of these 1,000 have the infection. You expect about 60% of them to be asymptomatic. You expect 40% to be symptomatic. And these are all real numbers. 60% of people infected with SARS-CoV-2 in India are asymptomatic. So out of these 50, you got 30 asymptomatic patients. You got 20 symptomatic patients. So out of these 100 symptomatic people you are testing that day, only 20 of them are actual patients. 80 of them have something else. I mean, what do the people typically come with? They come with a blocked nose. They might be coming with fever. There are 100 possible reasons for fever in this country. So how many positives will you get? For these 20 people who actually have the disease, you will catch 90%. That is 18. And out of these 80 people who do not have the disease, you will catch 10%. That's 8. So you will get 26 positive tests. Now, when you get 26 positive tests, 18 of them will be genuine positives. So you will get a positive predictive value of around 2/3, 66%. Now, this can be stated in two ways. 1/3 of the people that you will call positive may not have the disease. Now, that will happen. Why? Because you're generating so many positives from your uninfected people. So this 90% specificity is causing you to generate false positives, and that false positive is giving you a 66% reliability of a positive test. Now the thing gets even worse when you start looking at the asymptomatic people. Remember, to really contain this epidemic, with 60% of the people being asymptomatic, you have to reliably catch a good chunk of those people who are asymptomatic. Now, in these 900 asymptomatic people, as we said earlier, 30 people are infected, 870 people are not infected. Now, these 30 infected people will give you 27 positives, 30 times 90%. These 870 people, 10% of that is 87 positives. 27 plus 87 is 114 positives. 114 positives means you will get 27 positives out of 114, which is 25%, which basically means at these seemingly decent levels of performance, if you were to go around testing asymptomatic people and take a positive result seriously and act upon it, you will be wrong 75% of the time. That is the nuance created by COVID-19 testing in asymptomatic people because of the needs for isolation. And that is the reason why regulatory approvals are complicated for COVID-19. But is it a useless test? Of course not. You missed, in the end, only 5 out of 50 infected. You did catch 45 of them. Focusing on the symptomatic ones who need possibly more care, more treatment, you did capture 18 out of the 20. So these 18 did get captured. And the negative test, a negative result on the test would be correct in 855 out of 860 people, that is 99.5%. So when you went around screening asymptomatic people, a negative test would certainly be useful. You would be correct 99.5% of the time. There is some value to that. And when you're testing symptomatic people, you are correct 66% of the time. There is some value to that. So you could define the appropriate use case scenario for such a test. After all, the true sensitivity of PCR testing is actually less than 90%. It is only about 70 to 80%, 80% at best, 70% in real life, but the specificity is nearly 100%, which makes it useful. Let's change the number slightly to come to a test. I hope some of you will recognize this test before I actually describe it. There is a test that has 50% sensitivity and 99% specificity. It could be 99.9% to make it even more specific, like PCR. But practically, I'm telling you, because samples get exchanged, even when a test is 100% specific, practically, the specificity rarely reaches more than 90%, 99%. In this case, I'm exactly using the same figures as last time, so I'm not going to go through everything all over again, but the positive rates will be 10 out of 11, which means 90%. And even in the asymptomatic, a positive rate would still give you 60%. So you can see in asymptomatic testing, the confidence of a positive test here is comparable to what in the previous test it was for symptomatic people. If you were able, by not mixing samples, doing the test right in front of the patient, not transporting the sample all the way to a lab, right in front of the patient, you take the sample and you do it, you could probably get 99.9% specificity. And then even for asymptomatic people, you would have a 90% positive predictive value. So as long as you understood the next line, you will miss 10 symptomatic people with disease. 20 of them, half of them you will miss. So half the people who may need advanced care, you might call negative. So you need to understand that when you use this test, false negative is a problem. And when a symptomatic person is tested, and this test with a 50% sensitivity and 99 or 99.9% specificity comes back negative, you cannot stop. You must go forward with one more test, which is a more sensitive test. As long as you understand this, this test could be phenomenal if you could do it right in front of the patient. And I hope many of you in the audience today have guessed what test am I talking about. Yes, this is the rapid antigen test about which you hear in the newspapers every day. It's a matter the courts have taken up. It's a matter the government has taken up. It's a matter entirely of nuance. Now I'm going to complicate life a little bit more, as if I'd not complicated it enough already. COVID-19 stands for coronavirus-induced disease. Theoretically, a disease is not the same thing as an infection. There are many people in this country, maybe 30 to 40%, some people even say 50%, who have latent tuberculosis infection. They do not have tuberculosis disease. In COVID-19, we do not distinguish, for the time being, between people who are infected and the people who are diseased. And the reason is, from a public health standpoint of preventing the spread of infection, this distinction is useless. I mean, we want to isolate everybody who is infected. Whether or not the person is having disease is irrelevant to us. But for the person who's infected, it's very important. Those who are asymptomatic, whose infection will simply pass them by, and we are simply finding it out, it's very important to know whether they have the disease or they don't have the disease. We don't actually exactly know if there is such a state where a person is infected but undiseased. It's a semantic word I'm using to highlight a particular nuance that we have not yet discussed, but it does exist semantically somewhere. This is basically a patient asking you, how am I going to do? And this outcome prognosis also requires testing. These are also COVID-19 tests in a slightly different sense of the word. They're not molecular tests specific to COVID-19. They are clinical tests. And they are actually better than molecular data in trying to figure out who is going to do better and who is going to do worse. People talk a lot about CT values on RT-PCR, and I'll come to that later on. But to be honest, CT values tell you very little about the outcome and the prognosis. The oxygenation of the patient, the fall of the lymphocyte in the blood of the patient, the imaging, and I'm going to come to imaging in detail towards the end of this talk, are far better predictors of what is really happening. So let's go over the main classes of testing. The first, and probably the most important, the best type of test, is nucleic acid testing. It has the highest sensitivity and near 100% specificity with one caveat. We know the specificity is near 100% for established gold standard tests like qRT-PCR or next generation sequencing where you get the entire sequence of the virus. It may not be 100% specificity for newer tests like cartridge-based tests called CBNATs, or for CRISPRs, or for colorimetric lamps, which are easier and faster, but may compromise 1-2% on the specificity. Now, when we talk about 1-2%, I'm telling you in advance, practically it does not matter, because actually on the field, with qRT-PCR, the transport of sample, the contaminations of samples, mistakenly putting one person's sample in another person's name, all lead to 1-2% background false positives, which is not very different from what these tests do. And if these tests can go to the field, preventing these problems in the shipping and the transport, practically the specificity will be the same, and it will be very high for each one of them. So what are these different tests? If you're not a biologist, then explaining RT-PCR is probably going to be beyond the scope of today's talk, but basically, you start with RNA. There is something called PCR in which you can amplify DNA. So in the first step, you convert RNA to DNA, which is the RT, reverse transcription. In PCR, you amplify it using a quantitative system which measures fluorescence in a machine called a qPCR machine, a quantitative PCR machine. And these are expensive machines, about 20-25 lakhs. You can detect where there is any RNA of the virus in the sample that you just tested. Because it's a PCR, it goes through many cycles. The cycle at which the signal becomes detectable and clear is called the cycle threshold, called CT. The higher that number is, the less the virus was in the sample. The lower that number is, the higher the virus was in the sample. You can do this for one virus gene. You can do this for 3 virus genes. You always have internal control of the human, and together you can get very good results. When you use multiple genes with a control, the specificity is nearly 100%. When you use a single gene, you need to interpret the test a bit more cautiously, and the specificity is typically still in the high 90s. Now, you cannot do this without extracting RNA. So even before you do this test, there will be steps of isolating the RNA and extracting it, which make life a bit more complicated. I'll come to that in a subsequent slide. So then you have cartridge-based nucleic acid tests. In these, because you could just inject the sample directly into some kind of a cartridge, you don't have the step of virus RNA isolation. You don't need biosafety labs. They're easier, but they require those specific machines in which these cartridges are put. There are 2 of these in the market. One is called GenExpert, which was initially for tuberculosis. Today it is also there for COVID-19. These are faster than standard QRT-PCR. Standard QRT-PCR takes about 3 hours. GeneXpert is 40 minutes. TrueNat is also in the same category, about 90 minutes. These are single genes. Then you have a new class of tests, one of which my institute has developed called CRISPR. In CRISPR, you use a particular type of enzyme called CRISPR-Cas systems. And these systems can pick up a specific sequence with high specificity. You can couple them, Cas9, that is what a test technique platform called Feluda that IGIB developed. And I will take questions on that if you want later, which you can couple to any amplification method of RNA. You can use PCR, reverse polymerase that can happen at 37 degrees, or you can use LAMP, which is isothermal loop mediated amplification, again can happen at a single temperature. And you can then use CRISPR to detect whether your virus RNA was present. You do not need a qPCR machine. So basically in the first two, you needed a machine. In this category, CRISPR, you may not need any machine at all. In other tests by Harvard and UC Berkeley, you do need a cheap machine that detects fluorescence. It's not no machine at all, but it is still much cheaper than QRT-PCR. Even for the current ICMR approved version of our test that is in the market, you do require a basic thermoblock to do a basic PCR. If you plan to do PCR, if you use an RPA, which also a version 2 exists, it's there in a preprint in case any of you want to look it up under the name of Debojyoti Chakrabarti and Shauvik Mehti from my institute. And this does not require any thermoblock at all. So completely equipment free. The next category is the same LAMP test that you can use over here, but you tie it to a color generation. There are certain questions regarding sensitivity and specificity when you use visual color detection, but it is easy and fast. And of course, the big daddy of them all, can you sequence the entire viral RNA? Can you get the full sequence? And this is done by two methods. I will not get into details for the non-biologists. You can do it in a 2 lakh device that is the size of a pencil box, or you can do it on a mega machine called Illumina, which is basically the size of a desk. This is a 2 lakh machine. This is a 9 crore machine. You can have intermediate machines in the middle. You can do 100 tests at a time using nanopore. You can do 10,000 tests at a time using Illumina. All these tests our institute has done, and we found something very interesting. Even samples negative on QRT-PCR, about 10% of them contain the virus, which can be found if you sequence everything. And some of it is simply because the virus mutates, but the primers for binding to the virus in QRT-PCR or any of these tests remain the same. So you have a huge number of options when it comes to nucleic acid testing, and which option among these you choose depends on what your needs are. So when should you use nucleic acid testing? I think it's very simple. This is your test of first choice for diagnosing active infection in every symptomatic person. It is your test of first choice for high-risk people, people who have diabetes, hypertensive. If you miss them, you will feel bad later on that you didn't get them treatment in time. It is your test of choice when you're looking at somebody with a high pretest probability, a high-risk contact, like a spouse, for example. And it's also your test of first choice for a person who is high risk to transmit. If you're putting somebody on an airplane and they could transmit it to a large number of people, you really want a nucleic acid test to determine whether the person is safe for traveling or not. So very simply put, when you really need to know this person is infected or not, and you need to know it with confidence, there is only one choice, that's nucleic acid testing. But as with everything, even this nuance has a further nuance. What sample to take? Swab or saliva? Swab has greater sensitivity. Saliva is easy if you want to do more tests. Sometimes the bottleneck of testing more people is not that you don't have NATs available. It's simply that you don't have enough people to go to their houses and take the swabs. So saliva gives you certain advantages. In my lab, when we do the tests, half the time we take in doing the testing is not in the testing. It's in opening up the sample filled with swabs contained in media. And half our time goes in that. If we were not to do that, we could double, triple, even quadruple our testing capacity. So should you have swabs in these media? Should you have them dry? Should you have them in simple buffers? I'll show you some details. Should you extract RNA or not? Today, the larger cost might be in RNA extraction. The larger delay is in extracting the RNA. There are RNA extraction free methods. So many of these things about testing, which are not pertaining to the test, they are pertaining to how you set up the test, have greater impact on the scalability than just the biology and the chemistry of the test. In fact, I made this table for those of you who are biologists and are interested in this topic. The transport media we use for swabs actually inhibits RT-PCR. If you were to use a simple media like tea, a cheap buffer available everywhere, and kill with heat, you would maintain most of your sensitivity, get a very high level of safety. And there's a beautiful paper by Smirlaki et al. In Nature Communication just from a few days ago. Almost the same performance, much better safety, much lower cost. And we really need to think about these methods. Even with saliva, your sensitivity stays at 80 to 90%. Your specificity still remains perfect. Like I showed you in the previous examples, as long as your specificity is high and your sensitivity is good enough, if you can do more tests, that is more important than trying to reach a sensitivity of 95. And that is the one nuance that I really believe we need to think a lot about as a nation. So viral protein testing, the antigen test. The specificity is similar to nucleic acid test. The sensitivity is probably 50%. Original estimates at 70%. But it is the easiest test available. You can do it with no equipment. You can do more complicated tests like mass spectrometry. IGIB published that as well, with more sensitivity, but they are required very, very special facilities. They might be good because they're very fast, 30 minutes, very cheap, almost no cost. So what is the right setting for doing this test? This test would be preferred if you were doing field-based testing. A negative test would have to be followed up with nucleic acid testing. You really cannot let a positive high-risk person be left as a negative test. That is what we are doing wrong sometimes. You can do antibody testing. Antibody turns positive much later. It is not useful for diagnosing infection. ELISA and CLIA are better than the field tests. A positive antibody test does not confirm immunity for you. For that, you need something called neutralizing antibody. Only 80 to 90% of people who are antibody positive actually have neutralizing antibody. Do not assume a positive antibody to mean that you are immune. That's a common mistake people are making. Those with very high levels of antibody, yes, most of them do have neutralizing antibodies. But those are the settings for antibody testing. As far as possible, use the RBD domain of the spike protein as your first choice. Imaging. Imaging is not the best test for determining whether a person is infected. But imaging remains the best test for determining the extent of disease. You can find the disease even on a chest X-ray, low sensitivity, not very high specificity, but very easy, very fast, available everywhere. When you use CT scans, you will certainly have sensitivity better than antigen testing. Some people say as high as nucleic acid, but I'm not too sure on that. It depends on who you test. And reasonable specificity if you have experienced eyes looking at the scan in the right clinical context. And even if you don't have enough radiologists, artificial intelligence tools are doing a pretty good job on CTs. And these are just excellent in judging the severity of the case. So WHO says do not use chest imaging to diagnose infection in asymptomatic people, but you can use it in symptomatic people to guide your decision making when RT-PCR is delayed or when you want to know, is the patient really severe or not? These are examples of CT scans. You can see these white patches. That's what COVID looks like. You can see artificial intelligence tools marking the areas where the disease is present, and they're really, really good at it. You can see cases where AI is marking the areas of infection in a lung. The same patient is being scanned again and again until the time the lung is healed. And you can see AI is doing a wonderful job of marking the disease. At IGIB, we are working on diagnosing COVID, pneumonia, not SARS-CoV-2 infection, on chest X-rays. And we are reaching about 90% sensitivity and 90% specificity, the way I described in the first case. If you don't use it for asymptomatic, you use it for symptomatic, the use case is not bad at all. And these things are actually now available within India with AI tools built within India. Lots of interesting things in it. If those of you who want to talk a bit more about AI, I'll be happy to take questions in what we have learned about this. I would like to end by pointing out, no matter what your test is, if you want to trace and test some more, the results need to be available to other people who determine who to test, who to trace fast. That cannot happen without a comprehensive digital platform on which nation-scale testing is done. In India, I'm so glad to say we have done it. Every RT-PCR that is done is entered into a database. That database is available to a group of people who can then use it, tie it into Arogya Setu, do analysis, guide states. And this digital platform, the strength of India, has been really, really important in guiding testing. Although very often I feel the public is not aware of this at all. And this is just one of the very important things in the step between old India that used to only digitize things. You get an X-ray, you digitize it, to a digitalized India, to now in India that is undergoing digital transformation, talking about artificial intelligence, maintaining complete databases, doing contact tracing. Some of you may have seen the science paper from a few days ago. And I think times are changing, tests are changing, the way we transmit information is changing, and the way we use it is changing. Thank you all very much. I'll stop here. Happy to take questions in case people would like. Tanvi, I cannot hear you. Can you hear me?
Okay, sorry, sir. I was on mute.
Okay,
I did
all
not
right.
realize it. Okay, so thank you so much, sir, for such a delightful and a very informative talk. So I'll be picking up some points that I have looked at your slide, which is like I had a doubt regarding that the specificity that you talked about. So the specificity loses when you talked about when the person comes and takes the test and when he takes to the lab. So what happens? The specificity loses, or it is the same.
Let me explain that a bit further. See, the specificity of the test cannot change by taking to a lab. But if hundreds of samples come into a test, and then they are plated into hundreds of little tubes, and then mixed, you can see contaminations can occur. Wrong person can go into the wrong part of a plate, so technical errors can occur. So practical specificity goes down, theoretical specificity remains the same. So even though QRT-PCR is 100% specific theoretically, practically 1 to 2% error is observed. Practically,
Okay.
simply because hundreds of samples come to your lab every day.
Okay. Yes.
And even at the time of collection, right, if a little bit of contamination occurs, the test is not wrong, but the patient was not infected, but the test is might say it's infected.
It's infected. Yeah. So, is there any possibility, as in, like, the person is infected with coronavirus, but he has been asymptomatic, like, for a very long time, and like after a really, really long time, he shows symptoms? Like, is there any cases like that?
They're every type of case. Only thing
Okay.
is that to answer this type of case, you would need to know somebody whom you
Hmm.
tested for no reason earlier, and then later on they came back with symptoms, and these cases have occurred. In fact, symptoms are more severe around the seventh day. There are a
Okay.
number of cases by now in which the symptoms are almost nothing during asymptomatic screening. By seventh day, mild symptoms developed. By the 10th to 14th day, severe symptoms developed. That is the
Okay.
phase when the immune reaction becomes maximum.
Hmm.
And a lot of the damage to your lungs is not coming from the virus, it is coming from the immune reaction.
Yeah. Okay. Okay, I'll be okay. Before moving forward, I'd request our viewers to check the feedback forms. We will be sharing in a while in the comment section. So please do give us a feedback to enhance our streaming experience. So now we will be moving forward to a question and answers session. So I'd like our viewers to write down their and post their questions in the comment section so that we could collect and then post the questions to Dr. Aggarwal. So I so meanwhile I'd be posing some questions. May I?
Yeah, sure.
Okay. So the first uh, question is that can the COVID-19 test tell the difference between someone with an active infection and someone who has been infected in the past?
Yes, so in fact, all the nucleic acid tests or antigen test for the matter are for active infection. You would not expect them, you can say that, okay, for a few days after the infection is over, maybe a week, the nucleic acid test or antigen test might remain positive, but they will soon turn negative. They will not remain positive, let's say, 2 weeks after the infection has resolved. So, antigen and protein tests of the virus will become negative after the active infection is resolved, while antibody tests will remain positive even afterwards.
Okay. Um, so the moving forward to the next question. So who should get an antibody based test and RT-PCR based test? What are the benefits over getting one getting one over the another?
So let's start with one thing. There are almost no conditions in which you use an antibody based test for diagnosis of SARS-CoV-2 infection. You simply don't. When we had no tests, some people used IgM antibody tests, which become positive at 1 week approximately for this, mostly in Korea in the beginning. Today, you almost never use an antibody test to detect infection. There is one unique circumstance in which you would do this. A person is in the hospital, you suspect a COVID pneumonia, repeated nucleic acid tests have come negative, and you want to know, okay, fine, there is no SARS-CoV-2 in their nose and their mouth, but there could be SARS-CoV-2 in their lungs, but you don't want to put a bronchoscope into their lungs to get fluid out because the patient is sick.
Hmm.
If an antibody test comes positive, you can be very confident this person has a sequelae of a SARS-CoV-2 infection, either with living virus or with dead virus, pure immunological problem. But either ways, the treatment has to be of the type of a person with COVID-19. So in this case, I would do an antibody test. And in that antibody test, if it came positive, even though my nucleic acid test is negative, I would call this person a COVID-19 patient, and I would make one of two choices. Either I would go with a bronchoscope, get the fluid out, test for active virus, and treat with an antiviral, plus steroids, plus anti-IL-6, whatever I need to do. Or I would simply assume the virus is there and go with an antiviral plus an anti-immune therapy.
Okay.
And like I said, nucleic acid testing, if you have it
Yes.
and you can do it, do it. That's your choice, test of first choice.
Okay, sir. Okay, so the next question is, does testing tell us the spread of the virus? Like, what is the percent positive?
Uh, Antibody testing, also called seroprevalence, tells you the spread of the virus. See, because most people are asymptomatic, catching them in the active virus infection phase is almost impossible. But if you were to do serology in a sample, you don't have to test everybody. Take 1,000 people from a district or even 500 and do antibody testing randomly. The percentage of people who show seropositivity tells you that at least 14 days back, it gives you a 2 to 3 month history of infection. So when Delhi comes back 30% seropositive, you can say 30% of the people of Delhi suffered infection in a reasonable period in the past. And now imagine to yourself, Delhi is what? Delhi is 2 crore people,
Yeah.
2 crore, 3 crore people, somewhere in that range.
Yes,
So
around.
60 lakhs to 1 crore people got infected. The total number of RT-PCR tests is a very, very small fraction of this number. So
Yes.
you can see how useful
Hmm.
antibodies are to detect the spread of infection. And in case, just because I'm the director of a genomics institute, I can't help this. If you really want to understand the spread of infection, do sequencing.
Yes.
So in my institute for the Kerala government, we did one of those tests I was talking about, NGS for diagnostics. So we took hundreds of RT-PCR positive samples from Kerala and we sequenced them all. If you look under Vinod Skari and Sridhar Shivasubbu, you will find the preprint. They are the ones who did the work. And we could immediately find, based on the sequences, that the virus was actually very well controlled from foreign cases by Kerala. Where Kerala missed out, they didn't control the spread of the virus from Karnataka and from Gujarat and from a few other states, probably coming via road, not via
Hmm.
air.
Yeah.
So by tracing the sequences of the virus and the spread within Kerala, we could identify where the virus actually came from. So
Okay.
that's another way.
Uh-huh. Okay. So the next question is, so according to a study published in Science, 4 in 5 people with confirmed COVID-19 in China were likely to be infected by people who didn't know they were infected. So, is it is impossible to differentiate asymptomatic from pre-symptomatic people until time elapses, which are less contagious in asymptomatic patients and pre-symptomatic patients.
Let me answer that in a roundabout way. The word pre-symptomatic is about going back in time. So you can never call somebody pre-symptomatic until the symptoms have developed and
Yeah.
you've had a chance to reflect backwards upon it. So by definition that we live in a temporally forward world, you can never call somebody pre-symptomatic, you can only call them asymptomatic.
Okay.
And the spread by asymptomatic people is now extremely well established. There is absolutely no doubt remaining. In fact, the viral titer is highest, viral load is highest in the pre-symptomatic phase. But to say they are most infective in the pre-symptomatic phase is also wrong, because in the pre-symptomatic phase, your virus load may be the highest, but you're not going around sneezing and coughing.
Yeah.
But then if you change it back one level further, during your symptomatic phase, you have a mask on, and during your pre-symptomatic phase, you're mask free. So again, those people who don't use mask until after they become symptomatic, again it changes. And then you start using masks when you're pre-symptomatic and symptomatic, it again changes. So more and more nuances the more you think about it.
So masks do masks really help as in uh
All the data
is it
so
like a
far,
yeah.
all the data so far shows that effective R goes down with masks. The
Okay.
meaning of word help is to reduce the R. Once R goes below 1, it goes down. So social distancing and masks together reduces R. There is no doubt on that one.
Okay. So the next question is, what is the breakup between the RT-PCR kits and rapid antibody kits? Will rapid antibody kits be allowed for use in diagnostics for COVID-19, or will their use be limited to the community-level serological surveys announced by the ICMR?
Okay. First is an error in the question. An antigen test is not used for serosurvey.
Yeah,
Antigen is antigen, serosurvey is antibody,
yeah,
right?
yeah.
So the second part of the question implies there is a confusion. Serosurvey tests for the presence of antibody, which test for exposure. It's completely separate. Antigen test for the presence of viral antigen, which detects active infection.
Okay.
I don't think antigen tests will go away. I don't think so at all. And the reason is they're super easy. If you wanted to test for a health field worker to go to the field and do with no equipment, it's the only test they can do. Currently, 70% of the tests being done in Delhi are antigen tests, 30% are PCR tests. All over India, the number is now becoming 50-50. Now, this is the key nuance item I wanted to discuss. It's not wrong. It's absolutely logically okay to use antigen testing. As long as you use it for asymptomatic people and negative is called reliable, positive is called reliable in that case. But the minute you start using it to test symptomatic people and you start thinking that your negative test is reliable, then you're missing half the cases. So as long as you maintain this critical nuance at the back of your mind, use it, but use it in the right clinical context for the right purpose. I think antigen testing serves a very important purpose for a poor country with limited resources like India. I do believe, and I could be biased, of course, once the new tests like the CRISPR test of IGIB and Tata start becoming more available and accessible to people, there will be a scope that some of these people who are getting antigen tests, because there is no qPCR machine, but there is other machines. So it's not a zero facility setting, it is a low facility setting. Uh, there you could substitute with a nucleic acid test that is easier. So then I would, rather than saying 30, 90, 30, 70, I would hope to see something like 30, 40, 30, where at least 40% is simplified nucleic acid testing in low resource settings. But that I'm confessing my bias right here.
Uh, okay, sir. So there is another question that which schools and colleges planning to reopen throughout the country, and students have to travel back to either their schools or colleges. When in when in your opinion, like what is your opinion on this? Like when it is a right time to go uh, to the
Sure.
colleges and resuming the normal classes.
So it depends entirely on how much do you want to lower the risk. So in the IPL, which is currently happening in UAE, we were tasked with answering some of these questions. And the answer there was test them every other day, test them once, wait 4 days, test them again, keep them in a bubble in the middle, because you really don't want it to spread, because it's a very high economic value event. The consequences of being wrong are critical, right? So the answer was that. Now let's talk about a group of young people uh, living in a hostel at very low risk for bad outcomes from COVID disease. Let's take my institute's hostel, for example. Now, I'm not, I'm worried, but not super worried about COVID coming, because I know it will come eventually. I know it will spread. but I want to keep it manageable. I don't want our facilities to get overwhelmed. I don't want the hostel, the institute to shut down. So I would maintain a reasonable frequency, which could be once in a week for people who are willing to get tested. Obviously, it's not ethical for me to compel anybody to get tested. So every week, people who want to get tested can get tested. Everybody who's symptomatic must be tested. If you are entering people back into the hostel, you would call them ill, you would put them in quarantine, you would do a test, and you would wait until that test is negative. And you could do two tests separate by 4 days before you let them in. So first test negative, they come in, stay in quarantine. Second test negative, they can join the rest of the hostel. But I am a COVID testing lab, so I can afford to have this protocol. Each person will have to form their own using some combination of what is it that you want to do and what is technically feasible. I always think these things cannot be separated from each other. And the age of the person.
Yes, sir.
It's very important.
Yes, sir. So, sir, you have talked about the Feluda test uh, that CSIR has come up with. So, could you please elaborate more on the modified Cas9 protein that has been used for developing the Feluda test for COVID-19?
Sure. I will. Before I say anything, I must encourage you all to actually call Debojyoti or Shovik for an actual seminar on this.
We'll surely,
But
sir.
I will do the best I can. So first of all, Feluda is a platform. Feluda is not actually a test for COVID-19. Feluda is a platform by which we can test for any nucleic acid sequence or even a nucleic acid base two base discrimination. So pretty much I could discriminate between the two alleles for sickle cell disease using Feluda in one application. I could find either H1N1 or dengue or SARS-CoV-2 RNA in another application. The basic idea is the following. The enhanced FN Cas9 that Debo and the team invented, if that's the correct word, has a very high discrimination for even a single base difference and binds with a very, very high affinity if the sequence is matching, but doesn't bind at all if the sequence doesn't match. Which basically means that if I put this with the correct guide RNA, I can discriminate between sequences. So for DNA testing of nucleic acid, basically DNA testing for genotyping, I can create a single variant and I can deduce whether CRISPR is bound to it or not, and I can use the cleavage activity to find it out. Now in the Feluda platform-based test that IGIV patented, what we do are basically 3 steps. In step 1, you amplify the RNA and convert to cDNA. Now that can be done in 2 methods. One method that is part of the approved kit is the biotin-islated PCR in 30 minutes. In the other one, it is RPA, which is isothermal, as you know, at 37 degrees, which is even faster. Then you incubate with the sgRNA CRISPR complex that detects its target sequence and binds to it. Now this has a FAM label on it. And then you use antibody to FAM to drive flow on a paper strip. Now if both the biotin primer product and the FAM label on the CRISPR are both present, it will flow and hook onto a streptavidin line on the paper strip, creating darkness because of the gold nanoparticles present in the solution. So this will give you a positive band on a paper strip, and the total process takes about 15 minutes for RNA, 30 minutes for PCR, 10 minutes for incubation with the CRISPR complex, 2 minutes for the paper strip, add some pipetting, and you got 1 hour total. Now, if you were to use a faster method in which you don't extract the RNA, you simply use heated saliva mixed with a buffer, which contains a small amount of detergent, and then couple it to the RPA assay and use body temperature to run the reaction. Other things being the same, it takes 1 pipette, 3 tubes, and 40 minutes. That second one is not yet approved for use in India. because heated saliva for RNA is not yet approved for use in India. And if that is not approved, we have no great advantage by using more expensive RPA over simple biotin primers, in which case all you need is a simple thermoblock, right?
Yeah.
So the commercial version right now is biotin primers, and Tata will give it some name, which will be powered by IGIB Feluda.
Okay. So when is it expected to come in the market?
So Tata has started producing. We know that because the approval was for a Tata product, not for the technology. Now ICMR does not approve technologies.
Mm.
ICMR only approves actual products from factories.
Okay.
So production has started. Now India is large, and Tata will probably run more tests and everything. But hopefully sometime in October,
Okay.
probably end of October.
Okay. So, sir, the Feluda test, does it even distinguishes between the two different strains of coronaviruses?
It can. It can. So the so for human DNA genotyping, we use it to discriminate between allele. That's the way we build the RNA. For viral detection, we simply use the conserved part of the virus. Right? We don't try to use it to discriminate strains. We could if we wanted to. So in
Yeah.
one application that is there in the preprint that Debo and Shovik have published, for Helicobacter pylori, which contains two variants, one resistant to rifampicin, one not, resistant to azithromycin, and one sensitive to it. We have built a Feluda type of a test for AIMS by which they can distinguish which patient have Helicobacter pylori that is drug sensitive and which patient does not. So we can use it like this, but the commercial applications for viral diagnostics actually use the conserved part, which has no variation at all. So we use
Okay.
it as a dichotomous yes or no.
Hmm. Okay, so I guess we came to the end of our session. These were the questions. So now,
I see a few questions in the comments. Are those also questions?
yes, sir, we have been like compiling and displaying it the.
Ah, okay. Okay, okay.
So, yes, sir.
So last
Okay,
questions I see
so
from Devanshu Nandiya. Let me quickly answer you, Devanshu. Vocal changes, in my opinion, with low sensitivity, low specificity, and non-invasive techniques like this hold up against traditional ones. In emergencies, yes. In resourceful settings, no.
so um, so this was our last question then. And also, I would
Thank you very
want to
much.
mention that the feedback forms are in the comment section below. So please go and give us a feedback regarding the seminar. And yes, sir. And we have come to the end of the eighth episode of the series. Thank you so much, sir, for taking out your precious time and collaborating with us. I'm very sure that the audience have enjoyed it and is enlightened by the talk and hopefully clear the queries regarding it. Last but not the least, I'd like to thank you all the listeners who have been cooperative. We would be back with more informative and interesting talks, as Sir said. We would be taking a few of the speakers for sure. For that, please be tuned in with us, uh, and our social media handles will be displayed. Uh, and yes, wishing you all a great evening ahead, and wishing you all a happy Gandhi Jayanti.
Thank you all very much. Pleasure to be here.
Thank
Goodbye.
you. Goodbye, sir.